So, chapter 14, BLS resuscitation. And this is a review. You'll be required to complete your BLS resuscitation for healthcare providers through the Heart Foundation. And that must be completed before you're issued a certification from PHEMS for your EMT program. All right, the National EMS Education Standard Competencies for this chapter. We'll be looking at shock and resuscitation. It applies a fundamental knowledge of the causes, the pathophysiology, and management of shock, respiratory failure or arrest, cardiac failure or arrest, and post-resuscitation management. And the focus is really going to be on respiratory failure and arrest, and cardiac failure, cardiac arrest. That's what we're focusing on. Introduction. The principles of basic life support were introduced in the 1960s. Specific techniques have been reviewed and revised regularly. The most recent review was in 2020 and was conducted by the International Liaison Committee on Resuscitation, which is ILCOR. Elements of BLS. So it's a non-invasive emergency life-saving care. It is used to treat medical conditions including airway obstruction, respiratory arrest, and cardiac arrest. It focuses on the ABCs: airway obstruction, breathing, respiratory arrest, circulation, cardiac arrest, or severe bleeding. Ideally, only seconds should pass between the time you recognize a patient needs BLS and the start of treatment. Permanent brain damage is possible if the brain is without oxygen for 4 to 6 minutes. Which is why I keep saying to you, when you are conducting a primary assessment for a patient that's critical, you'll have 4 to 6 minutes to do that. You go outside of the 4 to 6 minute window, you will not be allowed to pass the skill station. So, time is critical. 0 to 1 minute without oxygenation or perfusion can lead to cardiac irritability. 0 to 4 minutes can result in brain damage. 0 to 4 minutes, brain damage is not likely, but the patient will start to show signs of poor perfusion to the brain. 4 to 6 minutes without proper oxygenation, the brain damage is possible. 6 to 10 minutes without proper oxygenation, brain damage is very likely to occur. And if it's more than 10 minutes, the patient is going to have irreversible damage. So time is critical for a patient who is not breathing, and we have a 4 to 6 minute window. Cardiopulmonary resuscitation, or CPR. It reestablishes circulation and artificial ventilation in a patient who is not breathing and has no pulse. And it's more specific for adults, because an infant or a newborn doesn't have to be pulseless for you to do chest compression. An adult needs to be pulseless. An infant or a newborn doesn't have to be pulseless. Know the difference. Now, CPR steps involve restoring circulation, and we do that by performing chest compression. We have to open the airway and maintain the airway. We restore breathing and provide rescue breathing using a pocket mask or bag valve device with oxygen attached. You must quickly identify patients in respiratory and or cardiac arrest so that BLS measures can be initiated immediately. And for BLS to be effective, you must have a good team response, and bystanders must initiate lay rescue CPR. So what does that mean? Somebody collapse, somebody recognize the collapse, activate EMS response, EMS dispatch, BLS or ALS response to the location, while ALS and BLS response is en route. The dispatcher gives the caller instructions to provide lay rescue CPR, which is really doing only compressions. Then when EMTs arrive, they will build on that, and when the AEMTs arrive or paramedics arrive, they will build on the EMT care. If there is nobody initiating CPR prior to your arrival as an EMT, then the patient prognosis will not be good. Rarely those patients will survive. So if you arrive on a scene and there's a patient in cardiopulmonary arrest and nobody has initiated any type of CPR measures, the likelihood of that patient surviving is very slim. BLS differs from advanced life support. ALS involves cardiac monitoring. It involves intravenous fluids and medication, and it includes advanced airway adjuncts. Now, system components of CPR. There must be recognition and activation of EMS. There must be immediate high-quality CPR. There should be rapid defibrillation. There should be basic and advanced EMS response, ALS and post-arrest care, and then we have the recovery. And the ALS and post-arrest care is done in the hospital. These are the 6 links in the chain of survival. If one of these links are missing, the patient's chances of surviving are significantly reduced. So we must have all of the links. And the most important link is that someone starts CPR prior to EMS arrival. And even better, if someone starts CPR and use an AED prior to EMS arrival. That's extremely important. So if the general public is not doing any CPR, that patient is going to have a very, very slim chance of surviving. Now, continuing with the system components of CPR, the AHA, or American Heart Association chain of survival, include recognition and activation of the emergency response system, immediate high-quality CPR by bystanders, rapid defibrillation by bystanders, basic and advanced emergency medical services, that's EMS, ALS and post-arrest care and recovery. Assessing the need for BLS. Always begin by surveying the scene. Complete primary assessment as soon as possible. Evaluate ABCs. Determine unresponsiveness, and it should not exceed 10 seconds. Basic principles of BLS are the same for infants, children, and adults. Although cardiac arrest in adults usually occurs before respiratory arrest, the reverse is true for infants and children. So what this is saying is that adult patients tend to go into cardiopulmonary arrest because of cardiac problems. And infants and children tend to go into cardiac arrest because of respiratory problems. Very important. Now, assessing the need for BLS. Assess an unresponsive patient by first attempting to rouse him or her by tapping on the shoulder. Sir, can you hear me? Straightforward stuff. Now, the automated external defibrillation, or AED. The whole point of doing chest compression and ventilation is to buy time until the AED is available. So CPR without an AED is pointless. The AED is needed, right? So we're buying time until the AED is available. So it's a very important link in the chain of survival. So it's a vital link in the chain of survival. It should be applied to cardiac arrest patients as soon as possible. If you witness cardiac arrest, begin CPR and apply the AED as soon as it is available. For children, apply after the first 5 cycles of CPR. And a cycle consists of compressions and ventilations. Use pediatric size pads and dose attenuating system. If neither is available, then use an AED with an adult size pad with anterior and posterior placement. Special situations for AED. Pacemakers, so the patient may have in a pacemaker or implanted defibrillators. You need to avoid putting the defibrillation pad over the pacemaker. Same thing with the defibrillator pad. If the patient is wet, we have to dry off the patient before we put the pads on the patient. If they have on a transdermal medical patch in an area where the AED pad needs to be placed, we need to remove that medication patch, wipe the area, and then put the AED pad in that correct placement, or in the correct placement. Positioning the patient. For CPR to be effective, the patient must be supine on a firm, flat surface. Very important. So if you find a patient in a bed that is not breathing and pulseless, talking about an adult now, we cannot do CPR on the bed. We're going to have to move that patient to a hard surface. You need a hard surface. And most units carry what is called a CPR board. So we have a CPR board. In the hospital setting, sometimes they pull up the head of the bed and slide it underneath the patient's upper body to create a hard surface. And I've seen doctors remove patients from bed and put the patient on the floor and work the code for that particular patient. So you need a hard surface, very important. Must be enough space for 2 rescuers to perform CPR. Now, your team needs to be clearly defined, and this is the confusion with how we conduct codes in the pre-hospital setting. I won't say in the hospital setting because there are more persons available in a hospital setting than in a pre-hospital setting, but it needs to be clear whether you're functioning as a 2-person team or a 3-person team or a 4-person team. And if you're working a code, for a code to be effective in the field, you need at least 3 or 4 persons. At least 3 or 4 persons. 2 persons in the field cannot do effective CPR. Can try, but it certainly won't be effective. Because again, 2 persons are needed to perform the BLS component of EMS, and 2 persons are required to perform the ALS component of BLS. So ideally, is 4 persons we would really want to run a code in the pre-hospital setting. And that is definitely the case in a first world system. In Jamaica, not gonna see that happening, right? The only service I currently know of that uses 3 persons is the fire service, and to the extent that that 3rd person is utilized is very limited because some persons just have the role of drivers. But it cannot be 2 persons managing a code in the field. It's just not going to work out. It's not going to work out. for that patient. You need more hands on deck. So must be enough space for two rescuers to perform and maneuver around the patient. You may have to log roll the patient onto a long board, or you may have to put a CPR board under the patient's upper body. You need a hard surface. Check for breathing and pulse. Quickly check for breathing and pulse, and it's a simultaneous assessment. Visualize the chest for signs of breathing, palpate for the carotid pulse. And how I teach it is position the airway, check that it's clear, look, listen, feel, simultaneously check for the carotid pulse on the side that is closer to you. Once you have determined that the patient is pulseless, then you need to start your chest compressions. So provide external chest compressions. Apply rhythmic pressure and relaxation to the lower half of the sternum. Compression squeeze the heart, acting as a pump to circulate blood. Avoid leaning on the chest in between compression. So you need to allow the chest to recoil. Elbows need to be locked. It's the motion of the shoulder going down. You're not bending the elbows. You're locking the elbows, and you're using your body weight to compress the chest. And most services use what is called a feedback device now, which is a device that you put on the chest. When you compress on it, it gives you a light that indicates whether or not your compressions are good enough. And the compression basically mimics the contraction of the heart. Allow the chest to completely recoil between compressions. Proper hand positioning is crucial. Injuries can be minimized by proper technique and hand placement. And even with proper placement and technique, injuries can occur. Some persons have brittle bones, so the bones fractures easily. And I've heard ribs crack or bones crack when I'm doing CPR. So even with proper hand positioning, injuries can occur. The heart lies slightly to the left of the middle of the chest between the sternum and the spine. Right, so you want to get your body or shoulders directly over your arms. Elbows lock, and you use the motion of your upper body going down to create the compression, and ensure that you release the compression to allow recoil. If you don't release, the blood won't go anywhere. So compression and relaxation should be rhythmic and of equal duration, 1-to-1. Pressure on the sternum must be released so that the sternum can return to its normal resting position between compressions. Opening the airway and providing artificial ventilation. So we will use the head tilt chin lift or the jaw thrust maneuver. And at this stage, you are very familiar with both of these techniques. So the head tilt chin lift is indicated for your medical patients or patient with no suspected spinal injury. The jaw thrust maneuver is for your patient that you suspect have a spinal injury. So these are the two techniques. You can also use what is called a control head tilt chin lift if the jaw thrust is not effective. Still on opening the airway and providing artificial ventilation. If the patient is adequately breathing and there are no signs of injury to the head, spine, hip, or pelvis, place the patient in recovery position. You're going to turn the patient on their side. The recovery position maintains clear airway and it allows vomiters to drain from the mouth. Roll the patient as a unit. And this slide depicts what the recovery position would look like. So the recovery position is used to maintain an open airway in an adequately breathing patient with decreased level of consciousness who has no spinal injury. It allows vomitous blood and other secretions to drain from the mouth. The combination of lack of oxygen and too much carbon dioxide in the blood is lethal. If patient is not breathing, ventilations can be given by 1 or 2 EMS providers. And you use a barrier device, which would either be your BVM device or a pocket mask. When you provide ventilations, use your BVM or your pocket mask. And the preferred BVM technique is 2-person. So 2-person technique is preferred. For a patient with a stoma, place a bag mask device or pocket mask device directly over the stoma. Artificial ventilation may result in gastric distension. Have a suction unit available in case the patient starts to vomit. So this slide depicts a patient with a stoma and breathing through the stoma. Now, 1 rescuer adult CPR. A single rescuer gives both chest compression and artificial ventilation, and the ratio for that is 30 compressions to 2 ventilation. That's 1 rescuer. In 2 rescuer adult CPR, which is the one that is preferred, so it's always preferable to 1 rescuer CPR because it's less tiring, it facilitates effective chest compressions. Switching rescuers during CPR is critical to maintain high quality compressions, and it is recommended to switch positions every 2 minutes. Once you start to get tired, your compressions will not be effective. Now, devices and techniques to assist circulation. So they have devices now that can help to assist circulation. They have active compression, decompression CPR, which involves compressing the chest and then actively pulling it back up to its neutral position. So they have devices that can do that. You have the impedance threshold device, ITD, which limits the amount of air going into the lungs when the chest recoils from chest compression. And this helps to improve circulation. You can definitely read up on these devices. So the one on your left is the compression device that creates active compression and decompression. So it's like a suction on the chest, and you push down and then pull. So it's active compression and decompression. And on the right is the impedance threshold that monitors the air flowing in and out of the patient. They also have what is referred to as compression, mechanical compression devices. So you have mechanical piston devices, which allows a rescuer to configure the depth and rate of compression. You have loading distributing band, CPR or vest, CPR. It's a device that goes circumferentially around the chest, and it creates the chest compression. So you don't have to physically do the chest compression. And you have manual chest compression remain the standard of care. So manual chest compression is the standard of care, However, the new guidelines state that if you're required to do CPR on a patient in the back of a moving ambulance, you should be using a compression device. So manual compression in a moving ambulance is no longer recommended. It is dangerous to you, the provider, and it doesn't do much for the patient. The way that is going to be effective is if there is two of you around the back. If it's only you alone around the back and you're trying to do CPR in the back of a moving ambulance, it's not going to be effective. And you're putting yourself at risk for injuries. So a device to create compression is what is now recommended. And this is the most common one. This is the one I was using in Texas, the AutoPulse. Lovely device, absolutely lovely device. Now, infant and child CPR. Cardiac arrest in infants and children follows respiratory arrest. I've already expressed this previously. Airway and breathing are the focus of pediatric BLS. So when it comes to the pediatric population, your ability to manage the airway will determine if they live or die. So you need to be proficient at airway and breathing management for the pediatric population. That is what is going to save them. Now, causes of child respiratory problems include injury, infections, foreign body, submersion, electrocution, poisoning, overdose, sudden infant death syndrome, which is SIDS. For your infant and child CPR, determine unresponsiveness, gently tap on the shoulder and speak loudly, check for breathing and pulse. Assessment occurs simultaneously, should take no longer than 10 seconds. Don't exceed 10 seconds with your assessment. For foreign body obstruction in children is common. Place an unresponsive breathing child in the recovery position. Techniques for opening the airway are modified for pediatric patients. So there are a few modifications depending on the size of the pediatric patient. So if they are very small or very young, we want to elevate the shoulders with padding. We want to keep the head in the sniffing position. We don't want to fully head tilt. We don't want to do a full head tilt chin lift for these patients because it can occlude the airway. So place a wedge under the upper chest and shoulders when supine. Still on infant and child CPR, provide rescue breathing. Now, rescue breathing is necessary for a patient when the patient has a pulse and is not breathing. So for adults, it's 1 breath every 5 to 6 seconds. The new guideline is 1 breath every 6 seconds. For your infant and child population, it is 1 breath every 2 to 3 seconds. Not breathing and no pulse, it's 2 breaths after every 30 compressions. That's 1 person CPR. If it's 2 person, it's going to be 2 breaths to 15 compressions. Now, interrupting CPR. CPR is a crucial life-saving procedure. If no ALS is available at scene, provide transport per local protocols. Consider requesting ALS rendezvous en route to the hospital. When to start CPR? Oh, not dare say it. Still on interrupting CPR. Try not to interrupt CPR for more than a few seconds. Chest compression fraction, the total percentage of time during a resuscitation attempt in which chest compressions are being performed, should be at least 60%. And what you need to keep in mind is that if you are doing chest compressions, the first 10 chest compression doesn't really do much. Somebody's mic is open. The first 10 chest compressions doesn't really do much for the heart. It's like you're warming up the muscle at that point so that it can stretch effectively. The remaining 20 is what create the contraction. So if you stop, you have to start over. You have to create a momentum with the first 10 compressions, and then the remaining 20 pushes the blood out. So it's very important that you don't interrupt the chest compressions for too long. Now, when not to start CPR? When not to start CPR? If the scene is not safe, if the patient has obvious signs of death, which include rigor mortis, which is stiffening of the body, dependent lividity or livor mortis, which is the pooling of body fluids in the lower portion of the body, putrefaction or decomposition of the body, the tissues start to rot, evidence of non-survivable injury, so the head gone, or the body is in pieces, or something goes straight through the chest where the heart is. If death is obvious, don't do any CPR. Dependent lividity. Dependent lividity is an obvious sign of death caused by blood settling to areas of the body not in firm contact with the ground. The lividity in this figure is seen as purple discoloration of the back, except in areas that are in firm contact with the ground, scapula and buttock, as dependent lividity. If the patient and physician have previously agreed on do not resuscitate orders, when in doubt, begin CPR. So if you can confirm that the DNR is valid, then you don't need to do any CPR. If you cannot confirm that it is valid, then you have to do CPR. When to stop CPR? Once you begin CPR, continue until the patient starts breathing and has a pulse, so that S is starts breathing. T, patient is transferred to another provider of equal or higher level of training. So the T in stop is transferred. O, you are out of strength, you're tired. The O is out of strength. And P, physician directs to discontinue. So you can use this acronym to remember when to stop. Foreign body airway obstruction in adults. Airway obstruction may be caused by relaxation of throat muscles, vomited or regurgitated stomach contents, blood, damaged tissues, dentures, foreign bodies. In adults, it usually occurs during a meal. In children, it usually occurs during a meal or play. Patient with mild airway obstruction is able to exchange air, but with signs of respiratory distress. A patient with severe obstruction will have issue with air exchange. Sudden severe obstruction is usually easy to recognize in responsive patients. In unresponsive patients, suspect obstruction if maneuvers to open the airway and ventilate are ineffective. So if you position a patient's airway and you're not able to ventilate adequately, reposition and make sure you open the airway properly. If you still can't ventilate, then it's possible that this patient has an obstruction, especially if you're feeling resistance. Abdominal thrust maneuver or Heimlich is recommended in responsive adults and children older than 1 ear. The abdominal thrust maneuver in a responsive adult: stand behind the patient, wrap your arms around the patient's abdomen, place the thumb side of one fist against the patient's abdomen while holding your fist. With your other hand, press your fist into the patient's abdomen using an inward and upward thrust. You want to create an artificial cough, and keep your thumb on the inside. Don't keep your thumb on the outside because your thumb is very weak. You can sprain your thumb. So keep it on the inside, and you're creating an artificial cough with that inward and upward movement. Instead of abdominal thrust maneuver, you can use chest thrust for the following responsive patients. If you have a woman or women in advanced stages of pregnancy or an obese patient, you can use a chest thrust. Removal of foreign body obstruction in a responsive adult using chest thrust. Stand behind the patient and wrap your arms around the patient's chest. Place the thumb side of one fist against the chest while holding your fist. With your other hand, press your fist into the patient's chest with backward thrust. So with the chest, you're going straight in. With the abdomen, you go in and up. And again, remember to keep your thumb on the inside. Your thumb is very weak, so you can sprain it very easily if it's on the outside. Now for your unresponsive patients, still on foreign body airway obstruction in adults, determine unresponsiveness, check for breathing and pulse. If the pulse is present and breathing is absent, attempt ventilation. If 2 attempts do not produce visible chest rise, perform 30 compressions, open the airway, and look in the mouth. Attempt to carefully remove any visible object. So you're doing CPR. The only variation here is each time you go to give ventilations at the airway, you need to check to see if you can see the object in the airway. And if you can see it, if you can physically reach it, remove it. Now, foreign body airway obstruction in infants and children, very common problem. If there are signs and symptoms of airway obstruction, do not waste time trying to dislodge a foreign body. Unresponsive standing or sitting child, perform Heimlich maneuver, and it's going to be really dependent on the size of the child. On unresponsive child, older than 1 year, manage in the same manner as an adult. So if they are unresponsive, the same approach as an adult. You're going to do CPR with the exception that each time you go to the airway to give ventilations, you're going to check to see if you can see the object inside of the patient's mouth, and if you can reach it, go ahead and remove it. To perform the abdominal thrust maneuver on a child, kneel behind the child on one knee, wrap your arms around the child's body, and place your fist just above the umbilicus and well below the lower tip of the sternum. So it's between the tip of the sternum and the navel. And you're going in and up, creating an artificial cough. Responsive infants, do not use abdominal thrusts, perform back slaps and chest thrust compressions. So hold the infant face down with the body resting on your forearm, support the jaw and face with your hand and keep the head lower than the rest of the body. Give the infant 5 back slaps between the shoulder blades using the heel of your hand. Give the infant 5 quick chest thrusts. So it's 5 back slaps between the shoulder blade and then 5 chest thrusts. until the object is dislodged or the patient loses consciousness. In unresponsive infants, begin CPR beginning with chest compression. Do not check for a pulse before starting compressions. Open the airway and look in the mouth. Remove the object if seen. Resume chest compressions if no object is seen. Now, special resuscitation circumstances. Opioid overdose, which is very common in the States, not very common in Jamaica. Standard resuscitation measures take priority over naloxone administration. So an opioid or opiate is a drug that reduces pain and causes narcotic effects. So it makes the patient sleepy. It decreases brain function. When patients overdose on opioids, it can decrease the brain function so significantly that it starts to affect their ability to breathe, and they can go into respiratory arrest and cardiac arrest. The treatment for opioid overdose or opiate overdose is naloxone or Narcan. That's what reverses the effects of opioids. And when I talk about opioids, I'm talking about heroin, talking about morphine, oxycodone, OxyContin, Dilaudid. All of these are opioids, same class. So what the guidelines state is that we're not going to waste time administering naloxone and delay CPR if CPR is required. If we know that it's a possible opioid overdose, we need to do CPR, and while CPR is in progress, we assemble the antidote and administer. So we can delay CPR to administer the medication. Now, cardiac arrest in pregnancy, priorities to provide high quality CPR and relieve pressure of the aorta and vena cava is important. So someone may have to push the fundus more to the left to ease pressure of the vena cava when you're doing CPR on a pregnant patient who is close to full term. And the head of the stretcher may have to be elevated to shift weight off the diaphragm. So there's a lot of things that need to be considered for a full-term mother who requires CPR. And there should be protocols that are specific for that type of patient. Now, grief support for family members and loved ones. Family members may experience a psychological crisis that turns into a medical crisis. Family members and loved ones will remember this event in detail for the rest of their lives. Keep the family informed throughout the resuscitation process. After resuscitation has stopped, helpful measures include take the family to a quiet private place, use clear language and speak in a warm, sensitive, and caring manner, exhibit calm, reassuring authority, use the patient's name, use eye contact, and appropriate touch. After resuscitation has stopped, helpful measures include expect emotion, be supportive but do not hover, ask if a friend or family member can be called, ensure that children are not ignored. Education and training for the EMT. CPR skills can deteriorate over time. That's almost guaranteed. So the skills that you acquire as an EMT, if you are successful within 3 months, within 3 months, if you're not utilizing the skills, they will deteriorate. and within 6 months, you probably won't remember anything you were taught. There's evidence to support that. So measures must be in place to maintain the skills that you have acquired, and you have to have a plan to develop yourself as a professional. So you can't just rely on your institution. You must have a plan for how you are going to develop your skills and your knowledge. And as your experience grows, you ensure that you acquire knowledge to match the experience, right? Acquire, sorry, qualifications to match the experience. If none of that is in place, as I stated, within 3 months, everything that you have learned is going to be gone. And that is why it is important that we have a dispatch system, a proper dispatch system with trained persons, because there are persons out there and there are organizations out there who currently offer first aid and CPR to the general members of the public. However, these persons there's no standard for first aid and CPR training in Jamaica. I've never seen anything that indicate that there is a standard. So each organization train persons in first aid and CPR differently, right? There's no set standard for that. And most of these persons that complete first aid and CPR courses in Jamaica, they don't do a lot of hands-on. It's a lot of theory. They don't do a lot of hands-on stuff, and it is not their core function. So after they have completed a first aid and CPR course, they go back to their job, their regular duties. And if something happens on the job, so let's say they have been certified in CPR, 2 years have passed, nothing happens. After 2 years, something happens, right? Or before it reaches 2 years, something happens. Any knowledge or skill they had prior to that event occurring would be gone. There's no way they would be able to do CPR effectively at that point. And this is where the role of a dispatcher comes into play. So when you have a proper dispatch system or proper leadership, the dispatcher can relay information to this bystander and say, okay, you're gonna have to do chest compression. And the bystander can say, you know, I completed a course 2 years ago. The dispatcher can say, good. This is what I want you to do for me, and give them instruction. And while getting those instruction, whatever they learned starts to come back. But when you don't have a proper dispatch system, and these persons go through a program 2 years ago, they haven't done any type of workshop, and then someone requires the skill, there's no way, it is absolutely impossible that the CPR that is done for that patient will be effective. It's just not going to be effective. So the skills will deteriorate over time. Practice often using mannequin-based training. So you need to practice these skills. CPR self-instruction through a video and or computer-based modules with hands-on practice is what is recommended for EMTs. So if you're working in an organization, you need to be doing workshops for your CPR skills and how you will respond to a code, how you're going to operate on the scene, how many of you will be in the team, who will be the team lead, who is going to be responsible for the AED. If you're incorporating ACLS, how is that going to work? So that needs to be clear. You cannot wait until something happens to figure out how this is going to work. You must have clear guidelines. and your training is ongoing. If you're in the medical field, your training never ends. It is ongoing. You must maintain your skills, you must maintain your knowledge, and you must embark on a journey for professional development, continued professional development, very important. Now, education and training for the public, kind of touched on that before. So as EMS responders, it is your duty to educate the people within your community about your role and function. It is your duty to teach them, at minimum, layperson CPR. They don't have to be certified, they just need to know the skills. Just knowing how to do good chest compression can be a significant benefit. So it is your role to educate, it is your role to train the public. The more the public knows and understands and is able to assist, the better your response will be for the patient. And that brings us to the end of this chapter.